Okay, so first, the recap of where things are to date. We are nearing the end of our long and very exciting journey of the VBP model development workgroup process. So we have today's meeting, we have next month's meeting, which will be focused on social risk adjustment, and then we have one more meeting in May, which is our planned final meeting where we'll be doing a synthesis and final review of the VBP model recommendations to date. Which will hopefully be the full comprehensive set of recommendations. We are asking for folks to please share in writing in advance of that meeting by May 3rd any feedback that you have on the model recommendations that would essentially prohibit your organization's endorsement and adoption of the model, meaning things that you really cannot live with. And our hope is that if we get feedback by May 3rd, we can potentially have some one-on-one conversations with folks in advance of the May 24th meeting, but then certainly bring to the full group any further issues that need revisiting as we finalize the model recommendations. Any questions or anything, Diane, or others that you want to add?
No, I'll just chime in on this. Is that the timing feels really important, and there, we do have some final items, as Alyssa mentioned, and I don't want to be surprised, by folks, saying, no, I really have a concern with that thing we discussed, in our May meeting. So really, we need to hear back from folks, and we will send this out to the other folks on the work group who aren't here, because the plan is we do have a collaborative meeting in April where we'll be going over the model, but we're going to be asking for their endorsement at I think it's June or July meeting, the next meeting after that, and so we want all of you as champions. And so if there are things that you cannot live with, we need to know that. And I'm going to say that's the bar, as opposed to I don't like it. so because we've had lots of good, extensive discussion, and we're working on a consensus and collaborative model. So there might be things you don't like, but we'd love to know if there are things that that are showstoppers for you that you can't live with. So that's all I'll say about that. Ask us questions, email me or Summer if you have any, or Chris, if you have any questions about that.
And I'll also note that in the email that Summer sent last week, she included the summary of all the recommendations to date. So we'll be adding to that summary based on the conversation discussion this meeting. And then we'll further add on pending the conversation on social risk adjustment, but you'll be receiving updated versions of that document, which is what we're asking folks to review and react to. Any questions? Okay, great. So moving on, for everyone who was at the last meeting, you know that we spent some time discussing strategies to mitigate against potential unintended adverse consequences of the VBP model. And we received some good feedback from those who were at the meeting regarding the language, making it more payer and provider collaborative focused, and making efforts to reduce any potential administrative burden on practices and payers for that matter in implementing some of these strategies. And I think the consensus at the end of the meeting is that the strategies were valuable, but we didn't want to have sort of a list of prescribed strategies. So we've included a menu of strategies that can be taken up at the discretion of payers and providers as this model is being implemented. And that menu is included in the appendix and also included in the actual recommendation summary. Any questions? Okay, so moving on to promoting health equity. As we discussed last month, the conversation around protecting against adverse consequences is really meant to ensure that existing inequities are not further exacerbated. So now we're going to be turning back toward ways that the VBP model can more proactively promote health equity. And as we've noted, and as we'll discuss, the model recommendations to date already take into consideration health equity in various places. But now we're going back and we're sort of looking at what the group has decided Are there places where we did not consider health equity where it should be added, or are there places where health equity was considered but where it should be further prioritized? So now's our chance to do that. So the first set of recommendations that we're going to be revisiting are those around quality measures and performance incentive payments. So we're going to talk about them together since they go together. So here's an abbreviated version of the recommendations around quality measures. As a reminder, the work group has determined that there should be a subgroup established that will determine what the aligned measure set will be. That group has yet to be formed, but we've been asking for volunteers and will continue to do so. That measure set will include a broader menu of primary care measures that can be used for incentive payments, and then a smaller core set of measures that would be used in all payer practice contracts. And as you'll see in the third bullet, when we talked about the measures, we did make reference to the fact that there could be appropriate equity measures, but that was the extent to which we included an equity consideration for this particular piece. I'll also note that we did, the work group did acknowledge that there should be no more than 8 measures in total for the menu. So the number is limited, but again, there will be discretion for the part of the subgroup in terms of what those actual measures will be. Oops. Okay. And then for incentive payments, this is a portion, an abbreviated portion of the incentive payment recommendations, but wanted to remind everybody that the recommendations include that practices should be rewarded both for high performance relative to an external benchmark, as well as for improvements over time, recognizing that practices are coming from different places. And in addition, that practices that serve patient populations with unusually high medical and/or social risk could be held accountable only for improvement if the payer and practice agree that an external benchmark is not applicable. So I think this came up at the last meeting too, wanting to ensure that that practices that do serve a disproportionate high number of patients with medical and/or social complexity are not sort of missing out on those incentive payments. And so those considerations were taken into account in the work group's prior recommendations. So now, thinking about whether there should be a greater focus on equity in the context of these quality measures. So as this work group is thinking about developing a primary care measure set, we could give the work group some additional parameters around that work. And one is that the measure set could include one or more equity-focused measures in that broader menu. And then another option is that the core measure set, meaning those that would be used in all payer practice contracts, would include one or more equity-focused measures. So what do you all think about adding one of those recommendations into the VBP model? Yes, Deborah.
It is really hard to opine on that if I don't know what the equity measures are. And so I can't, I don't know. So that's my initial thought.
Yeah. And I think as you may recall, when the group was discussing measures, it was hard to reach consensus on what the measures would be. And so again, this is to say, as this work group is beginning its process, equity should be something that's considered, and it's not, not necessarily mean something that's required, but I think we would say that it is left up to the discretion of this subgroup in terms of what the actual measure is. And so unfortunately we can't get any more specific at this point. Does that make sense, Deborah? Or
yeah, I'm struggling. I'm trying to figure out like how we could and I'm trying to discern the difference between the two, first of all, as I'm reading it. So you're saying, one, that if you choose a primary care measure, you must include an equity measure, and the other is that it's just included in the set that you could choose from?
So the recommendations to date have a subgroup determining a broader menu of primary care measures. And then a subset of that broader menu would be the core measures for use in all contracts, but then there would be discretion to use measures from that broader menu as well. So we could say, we could give a recommendation or sort of a parameter to this subgroup to say, within this broader measure set, let's make sure at least one measure is equity focused. And, you know, we could be more specific around what equity focused means, or we could leave that up to the subgroup to discuss and determine what that is. And then the other number 2 here is saying that for the core measure set, so measures that we know are going to be used in all payer provider contracts, that should include an equity focused measure. So the second would sort of guarantee that there's inclusion of an equity focused measure in an incentive payment. And the first would more would increase the likelihood that an equity focused measure would be included.
And to some of the questions, Bill Dwyer has a question about examples of equity focused measures, and I do wonder if that would help, because Brian and Dawn also chimed in that they agreed with Deborah. And I don't know, Alyssa, if you have thoughts about that. We also have Ignatius here, who could chime in.
So obviously the one equity focused measure in the CCO quality measure set is around language access. And so it'd be something that would be specific to something like that. There are other measures that I've seen around training, around workforce. So those would be, you know, diversity of workforce, incorporating traditional health workers, those kinds of things.
Thanks, Ignatius. Alyssa, did you have anything you'd add to that?
No, I think those all make sense. I mean, there's also measures around, you know, collection of race, ethnicity, language, disability, and SOGI data. So that's another example. But again, I think the goal here would not to be prescriptive, but to really let the subgroup make that determination. But I think it's certainly helpful to talk about what those examples could be.
So Miranda likes option 2. So I think that I hear the concerns about, well, we don't know what it is, but I think that it's either you have something in there that says you should use equity focused measures, or you don't. And so yeah, that's the sort of, either you do or you don't. And then if you do, you could choose one of these 2. Yeah, I think that's probably right, Dawn. People are still, unless Ignatius, do you see the chat? Is that?
No, I think that's right. So Oregon is one of the first to use that language measure.
Yeah. Go ahead, Deborah.
Oh, thanks. You saw me unmute. I think that this is really important, and we're still trying to figure it out. And I think that I'm really interested to see what, if any, differences there are in what we emphasize with this OHP population and the commercial population. And I also think that there's a significant variation based upon many factors of our primary care clinics, depending upon the populations they serve, age, demographics, and many other things that we might want to focus on some different areas. So to me, I like having something that is focused on equity, but I don't like it being prescriptive. So whatever option that is, maybe that's number 1. I think that we need to figure this out, and the CCOs are helping us by directing us in certain areas. And I think that we're getting our feet wet there. And I think that we're trying to figure out how that then applies to that whole population. And it could be that they need to start out process as we get better at collecting data on demographics, or until we have a commercial saying that they'll pay for traditional health workers, we can't put that as a measure, and so it kind of depends on but maybe they want to support that. So I think that while I know we want to be prescriptive, I think we need to be flexible in this area as we look at it, to allow for creativity and figuring it out.
Thanks, Deborah. I think Dawn was next.
Yeah, hi. I agree with Deborah. I think that it's actually important for us to acknowledge that there is a gap in terms of standard metrics that are out there. And so this would be our recommendation, except for that they don't currently exist. And so I think we could have a list of potential options that health plans could consider when developing their VBPs. And that could include some of the lists that Alyssa showed around how to sort of reduce the unintended consequences. I think it sort of should all go together around, here's a way to reduce unintended consequences and promote health equity. And the list could include a lot of different things, right? That we've talked about, like breaking down, when possible, breaking down metrics by demographic information to identify, subgroups that may be experiencing inequities. Also linking incentive payments to relative performance rather than absolute improvement, I feel like is a really important strategy that I've been seeing in the literature around equity, and making sure that those, and that also helps against cherry picking as well. So I feel like that's something that we should definitely highlight, but I think it's a list of options. And I think we need to be very clear that we are early in this. We do not have standard metrics yet. And that here's some considerations and options for health plans to consider in this space.
So Don, I just want to clarify. So your recommendation then would be not to sort of include these equity considerations within the recommendations of what the aligned quality metrics subgroup is discussing, but to have it sort of as a separate component of the VBP model recommendations as things that can be considered.
Well, I guess I'm thinking in my head, I'm sort of grouping the mitigating unintended consequences and promoting health equity as sort of one category. But that's just Dawn's brain. Others may not think that way, but like, I think there's overlap there. And so to me, it sort of ends up in the same bucket. And so Alyssa, I'm not sure if I answered your question, but that's how I'm thinking of it, because it's a whole long list of things to do. And there's overlap between the mitigating unintended consequences and the promoting health equity. But it's important to call out the health equity. It's just that the list of strategies is going to be similar in a lot of ways.
Yeah, so there could be strategies around equity, certainly outside of the specific quality metric component too. Miranda?
Yeah, I guess I might be simplifying this in my brain a little bit too much. So the way that I'm reading this is all of that would be discussed in the subgroup.
Correct.
So we don't have to, we're not deciding on measures. We're not getting a list together right now. We are deciding on the parameters that we will give the subgroup. And the way that I understood number 2 on here, which is the way I decided to vote, was that it would absolutely be part of that conversation. We would say we want this to be part of the conversation. Number 1 and number 2 are worded kind of funky. I will say. I think
it's the nature of the way that we talked about this core and menu measures that. But I guess I'll just say 1 and 2 both mean that the subgroup has to consider equity. I think 2 is slightly more prescriptive because it says that an equity measure has to be in the core measure set versus an equity measure should be considered for the broader menu. So maybe perhaps it's more toward 1 in terms of what you're envisioning.
I think I'm switching to 1. Yeah. Because I think, I sat here and read this over and over and over again, like trying to pick out the differences in this. But I think we're moving in this conversation, and this is just me in this conversation of everything that has been said is really important, but I think that's what the subgroup is supposed to be developing. That's, I guess, what I wonder if we're heading too far down a road.
Yeah, I guess I'll just say I agree. I think all of the feedback has been important. I agree that it's something that these types of conversations and points can all be part of the subgroups conversations as well. Whether or not it's included formally in the VBP model recommendations and parameters and still going to be part of the subgroup's discussions, but the question is whether to sort of explicitly put it in the parameters of what we want the subgroup to be talking about. Bill?
Yeah, I think maybe that covers it. What you were just saying. I was just going to bring up the point. I mean, if we've only got 8 measures, and we know that a few of them have to be pediatric measures, say we do 3 pediatric measures, well then to include that in the core measure set, you're sitting there saying, okay, should I measure translator services, or should I measure colorectal cancer or diabetes treatment? And it just, would you really kick out a measure on diabetes treatment because you want to know how many translators you have? That's going to be tough to make that call.
Yeah, I mean, 8 measures in general is going to be tough. It's going to be a tough conversation, but yeah, point taken. Thank you. Deborah?
I think this is a comment for the subgroup, but I'll just throw it out there for consideration because it's something that I'm grappling with. I do think it's important to separate when we start to go down that path, these metrics by demographics or real D or whatever categories per se, in order to identify populations that may be experiencing disparities in health. The challenge, but just for something to consider as one is doing that, is how small the populations get so quickly. And so it becomes very difficult. It's difficult to begin with when you're looking at your full population. And then as you break it down for a certain age group, and maybe these are, for a certain age group, whatever that measure may be, it gets pretty small. And then you break it down by health plan and then by product. I mean, it gets small very, very quickly. So I just want to throw that in as for consideration when we're talking about this, especially by health plan.
Yeah.
So I wonder, given this conversation and all, and again, if I struggle with language too, but if number 1 gives a little more flexibility to the work group, that I'm hearing give more flexibility to the work group and maybe some direction about, and we can even stick this in the model somewhere, but that recognizing that there are no standard health equity measures, right? Number 1. Number 2, I hear to Dawn's point and others, and Bill was like a list of options, right? And this is directions to the work group, and then they can sort of wrestle with some of this. So I'm hearing maybe number 1, adding on that there aren't any, recognizing this is still new territory, and asking the work group to provide direction with flexibility. Does that make sense to folks? Okay.
And I think, yeah, I think that makes sense, Diana. And I think we can definitely sort of tweak the language around 1 and put it so that it's even, more sort of framed around recommending that the subgroup consider inclusion instead of that the measure set include, it can be a consideration type of framing, again, to give some more parameters to that subgroup, again, so that we're not just, and I'm just going to pop up 2 slides real quick, because so that we're not right now, mentioning equity just in this parenthetical way, so that it's pulled out sort of more explicitly, but again, as a consideration of what the subgroup will decide. Okay, so any objections or concerns with that approach? Okay, seeing none, we will move on. Thank you for everyone's feedback. So next, we're going to talk about infrastructure payments. And as you all may recall, the VBP model recommendations to date include a base payment tied to PCPCH tier. And then we came up with, and you all helped to generate a list of additional services that can be included in additional infrastructure payments at the payer and provide and practices discretion as agreed upon. And this list here is not meant to be exhaustive, right? This is just sort of a menu, but not an exhaustive menu. But there are a number of items already in this list that would promote health equity. So care management and care coordination for patients with high medical and social complexity, traditional health worker services, addressing health-related social needs through screenings and other collaboration and data sharing. Okay, so the list already includes a number of infrastructure payments that would promote health equity. And the question for you all to think about is whether there are additional services to add to that list. And again, none of these are required. They're just sort of options or suggestions to think about that would promote equity. And these two here, I believe, came from a prior meeting of the full collaborative when we asked people to think about ways that equity could be promoted via infrastructure payments. So these additional options would be funds to help practices invest in infrastructure for collection and use of REAL-D, SOGI, and health-related social needs data, as well as more kind of pulling out explicitly funding EHR linkage and ongoing connections to community information exchanges so that practices can share data with social services organizations. So these are two additional things to add to that list on the prior slide. And then if there's anything else that comes to mind that we think would be useful to add, we can do that as well. So before I move on to number 2, what I want to hear some thoughts on the options under number 1. Are there any objections or concerns with adding these two to the list? No concerns?
Alyssa, hi, this
Brian,
is
yep.
Lauren. Sorry, I didn't raise my hand. Well, okay. What's going through my mind is that we already are suggesting that infrastructure payments are linked to PCPCH tier, right?
Mm-hmm.
And in theory, the higher the tier they have, the more robust types of services they're providing. But because of the way the Oregon's PCPCH program is structured, there's no way for us to sort of easily identify which practices are doing these high value things just based on their tier level. Now, I did note that in the proposed changes to the PCPCH standards that would be coming out in 2024, that there would be sort of a health equity designation or like achievement, that they would be sort of designated as a, doing more stuff in that area. I also believe that we need that for behavioral health integration, especially considering the substantial literature around cost offsets and cost savings associated with behavioral health integration. But I just think it's really important that as we talk through these things, it's like, okay, what's included and sort of acknowledged in that PCPCH differential base payment tier that in theory would be covering some of these things. But again, like from a payer perspective, like it's difficult for them to know which practices actually have traditional health workers, for example, or even have integrated behavioral health. Oh, good, Deborah. It's good to know that I wasn't the only one who made that recommendation. And so that's what's going on my brain, not to take y'all down a totally different path, but I feel like that's important, right? Because it's like, even for things that we're talking about carving out of capitation, right? And having still paid via fee for service, it's like, what are those things that are theoretically included in the base payment linked to PCPCH tier, and what really does sort of warrant and need a separate designation and separate additional payment?
So I'm going to go back up to this slide just so that I, so we're all on the same page around sort of what the oops, I'm going the wrong way now. Wait, there we go. Okay. So I just want to make sure, Donna, so you're saying essentially for number 1 here, for the base payment tied to the tier for infrastructure, we need to be more clear about how how to identify what a practice is doing in the realm of some of these equity related services?
Yeah, so if they're getting a $3 PMPM based on being a tier 3, maybe a $4 PMPM based on being on a tier 4, and those are the infrastructure payments, then we're saying here that then those payments should be higher based on sort of some of these things. Is that what we're saying? Sort of what's included just on that tier level, because if they were doing more things and they move up a tier level, they'd be getting higher base payment anyway.
So
I may not be phrasing this correct
Yeah.
in a way that is easy to understand. So if somebody else is following what I'm saying, please jump in too.
So my understanding, and people should jump in here if this is not right, but was that that sort of 1 and 2 would be 2 separate components of the infrastructure payments. That one would be sort of this everyone gets this base payment if they're a PCH and it's tied to tier, but we're not necessarily tying those to specific activities. It's sort of that's a component of it. And then 2 would be additional infrastructure payments tied to one or more of these services. And here's kind of a suggested list, but again, not an exhaustive list.
Yeah, yes, except, right, I think for traditional health workers, pharmacy, and integrated behavioral health, there's an argument for having that be a separate additional payment for things like care management and care coordination. I would think that that is sort of acknowledged and paid for with the higher infrastructure payment that they'd be getting based on their tier level. So that would sort of be included in number 1, because again, it's just based on tier, and tier equals the robustness of services they're providing. However, there are certain things where it really does need a separate payment in order for it to be financially sustainable.
So Dawn, is there a specific change you would suggest? Like change this to do this or do that? Just because I want us to get clarity on that. So is there a specific proposal?
I would probably suggest removing the first bullet point under number 2.
Because that's in the base payment.
That would be my thought. But also is a part of that thought, right? We're already considering medical and social risk adjustment for payment. And so that also would sort of be capture those pieces. Also addressing health-related social needs. I mean, this is something that is in multiple PCPCH standards that at the higher tier levels, you can almost bet that practices are going to be doing this stuff. And I personally don't know that it warrants a separate payment in the same way that integrating traditional health workers, integrated behavioral health, and integrated pharmacists need. And pharmacists may be captured under fee for service.
So let me try something, Dawn. I'm sorry to interrupt you, but I want to, it says as agreed upon by the payer and the practice. And so the payer would have to agree to it and the practice would have to agree to it. And what I worry is a little bit about some of the feedback we've gotten from folks on this work group is about getting so into the weeds and so prescriptive that folks can't even, because there's too much, that the feedback we've been getting in some of our conversations is there's too many details here that I have to track, as opposed to here's some options, folks. These additional payments, consider them. We're not saying you have to do them. We're not saying you don't have to do them. We're saying the payer and the practice can discuss them. So I'm worried about getting so deep in those details, given some of the other feedback we've gotten, if that makes sense.
Sure. I guess I was looking at simplifying by removing some
I
of the
hear
bullet
you.
points.
I appreciate
Because
it.
I really think that the PCPCH based payment captures
a lot of this.
several of those things. And so there should be a limited list of what it is above and beyond.
And I see Bill's hand too. I just want to ask, would it help, I mean, to say something like additional payments, not captured under the base payment? I mean, something about distinguishing the fact that we're talking about services that are not already included, or would there be a situation where maybe the base payment, infrastructure payment, is not sort of sufficient and a practice is looking for additional resources via an infrastructure payment to add to that? I just don't know, but that's a consideration, I guess, for not removing.
I'm curious on Bill's thoughts.
Okay, yes, Bill.
Well, I would just, in response to just the discussion about, here are some options. The thing is, so I'm just going to illustrate, an example of some conversations that I've had, and this applies to both the MODA business and our Eastern Oregon CCO, is that, when stuff like this comes up, I mean, here's how it goes. You get a bunch of people in the room that are decision makers, and we all are sitting around, okay, maybe it's traditional healthcare workers, and somebody says, well, should we be paying for these? And then it's like, okay, and they debate the pros and, well, what should we pay? And how should we pay it? And then we churn up a bunch of time, and it's 30 minutes, and somebody says, well, okay, somebody, can we do some analysis? Well, we don't have any data. Well, how are we going to even make this decision? And then it's on the agenda for a couple of weeks later. It means we don't need a list of things to consider. There's a million things that we can consider. What we actually need is somebody just to say, here's how you should do it. And this is a role, like lists of options are not helpful. It leads to just burning up a bunch of time, and that's happening at 16 different CCOs and a half a dozen major insurance carriers. We're all going through this. The single biggest thing that people could do for us would just be able to say, here is a specific thing that you could do. And for all of these things that are listed here, an example of that might be if we had, if that was included in the PCPCH standard, and maybe there could be more levels. Right now we have 5 levels, but there aren't really any 1s and 2s. So for all practical purposes, I mean, most of the PCPCHs are level 4 and 5. Maybe it's time to say, all right, the minimum now is level 4, but it's not even level 4 anymore. It's 1 through 10. And a level 4 right now is a 1. And here are all the different things that you can do, and they're each worth a certain amount of points. And here you go, and it's tracked centrally. And then a carrier could just say, all right, if you meet 80% of the points, you get 80% of the infrastructure payment. That's something that we can implement right away without, churning up a bunch of time and having that happen at 20 different, insurance carriers all across the state. That would be the thing, the type of thing that could come out of a group like this, or could come out of the OHA that MODA and Eastern Oregon CCO would find enormously helpful.
Can I ask Bill, just to follow up on Don's question of taking some of them? So you're saying make the list shorter, like agreeing with Don, like make it shorter, either no options or fewer options.
I'm saying that the options themselves, I mean, it's not helpful to have a bunch of options.
Okay.
Whether there's a short list of options or a long list of options, it's not how many options there are. It's the specifics of here's how we recommend you do it.
Got it.
Mm-hmm. So another follow-up then, Bill. So for the purposes of this model, because we're not getting into changing tiers for the PCPCH program, right? Are you saying that for number 2, we can just say additional payments as a sort of agreed upon, and just not, I mean, because I think the options were there because there was some acknowledgement of things that could be useful from the practice's perspective for infrastructure.
I think that you could summarize my point of view on this by saying, I think the recommendation should be to have a standardized system of evaluating all of the different types of services that are not billable on fee-for-service basis would be worth, and having a standard methodology for reporting on who is doing these things that carriers could use. So it's not, not the fact that we need to decide which things show up in a list, but rather that we recommend that somebody maintains a list and collects and maintains the data on who is doing what.
Right. And I think, if I'm remembering correctly, there was some discussion about this in the context of infrastructure payments in terms of having OHA look into how much, you know, sort of what it would cost to do certain things as a resource. And I believe OHA was looking into that. But we can revisit that too. Deborah?
I just put it in the chat too. And I can't remember now the two that we were asking. Should it be added to this list or not? But I think that whatever this list is, I think it would be nice to have a direct kind of correlation to the standard that is in the PCP that it applies to. So I know that there's a recommendation for a traditional health worker. There's recommendation, I can't remember the pharmacist service standard. There's a health related social needs standard. There's an integrated behavioral health standard. And so I think that if we could link directly to those items, that could be the validation that a clinic is performing those services. And
sorry, go ahead.
Nope.
I was just going to mention, so I just put in the chat, we did include that in the recommendations to date. So your point is well taken, and it's already in the summary. I just didn't include it on this slide because I was trying to abbreviate, but yes, that's already in the recommendations to date, having that validation component there for.
And I think that what I heard from I kind of a blend of the two considerations, and it's hard to know how the updated standards will play out. I know that they're looking at different point levels and tiers, but I don't know that it correlates necessarily to, like, the number of points means that you for sure have a traditional health worker or, you know, otherwise. So I do still think that there's a blend that might be needed, but maybe what's needed is some recommended value of like what it might generally be to support a traditional health worker or an integrated behavioral health or something as a suggested infrastructure payment for those items should they qualify. And so I kind of like that blend and agree with Dawn that to some degree, like, we need to think about calling out, you know, what requires like a new set of credentials or a person that has not previously been employed or a service that hasn't previously been done. That's what I think is really helpful. Like, if we're encouraging people, we think that it's important to have pharmacists. We think it's important to have integrated behavioral health, and we really want to encourage that so it can provide those services. We pay for it. And so, you know, and it's a blend, and that amount is a blend of, you know, all of them probably have some kinds of codes, but maybe not paid consistently or valued at the right level. So there might be some way that partially covers that cost, but not fully. So that's what that infrastructure payment should cover, is kind of that delta between the cost of providing that service and the reimbursement that's currently offered in the system we're stuck with. You know, and so I think with that, I'm agreeing with Dawn, and I think that you can look at it through the lens of like, what kind of requires that additional expenditure on the clinic side in order to provide that service or supervision or, you know, whatever that may be, and link it to the PCPCH at the same time, like you said.
Okay, thank you. Brian?
There it is. Yeah, I want to agree with Bill. I think having support for ways to do this would be really much more helpful than a huge list. I wonder if one of the things we're trying to say, though, is there could be, you know, I mean, there could be a million things on that list, and maybe while we're also recommending that certain things be tied to PCPCH, that there is a small, whether it's PMPM or some figure that is just an innovation infrastructure payment, so that it is not tied to, you have to do this one thing with it. But, you know, we recognize that our patients, for example, all have, like, you know, our patients can't afford bus fare. So we're going to use this innovation fund to purchase X number of TriMed passes so that our patients can get to and from an appointment. You know, that may not ever make it into the PCPCH standards. It may never make it, we may never think of putting it into a list, but maybe we just need to have a set amount of money that's, like I said, for an innovation fund.
Okay. All right, so what I am hearing for this topic is that we should, in terms of thinking about number 2 here, perhaps add some additional language clarifying that we're really talking about things that are not already paid for, covered under the PCPCH program. And so there may be things to think about taking off, or even, as Brian said, potentially adding a sort of a bullet around an innovation fund that would be used at the discretion of the practice based on what they identify as a need, but that we also, the group is looking to revisit the recommendations that were previously raised around having there be some kind of resource of what it would cost, what the value would be of providing some of these infrastructure payments to cover some of these services, and that would be useful in terms of thinking about these services. So I'm hearing, I'm thinking we wouldn't necessarily remove 2, but maybe amend some of the parameters around 2, but then also revisit something that this group has talked about before, which is, again, this resource around value. Liz?
Yeah, hi, thanks. I, listening to the conversation, feel like I heard slightly different things from Bill and Brian and Deborah around sort of valuing of services. One is like, what's the delta? So how much does it cost to provide the service? And how much do we currently get paid to support the infrastructure of that service? One's around return on investment, which is, I think, what I thought I heard Bill getting at, which is, you know, if you do these things, it's more likely to have a good outcome. And how do we have somebody who's tracking over time what the high value things are? Because it's hard to do that. And then the other piece is around being responsive to a community that might be, you know, say we track over time, we're like, yeah, integrated clinical pharmacy absolutely adds value to this population. It's going to decrease your readmissions, your total cost of care will go down. Let's add, you know, here's the delta for what it takes to supply clinical pharmacy within a clinic that, you know, you can't currently charge for clinical pharmacy visits for a fee for service. Here's the delta, we're going to cover it. But I think the other piece is there are some community needs like bus fare that are going to be value added, but not defined by those prior to. So I actually think it's 3 separate things. And I'm not clear if I'm articulating that in a way that makes sense to anyone. 3
categories of infrastructure payments, is that what you're saying? Or 3?
So under list 2, I would say there are sort of 3 things that could be, if you're looking for not a list of things, but general parameters to continue to consider, then sort of the general parameters would be something with a delta, a service that the practice wants to provide but isn't covered in the PCPCH infrastructure payments. Or the second would be from an insurer standpoint as an incentive to the practice. So that would be like as a support to the practices to maintain services they already have that are delivering value. So like there's a delta for clinical pharmacy. So how do we cover the delta? So that's from a practice lens. How do we support what they're doing that adds value? And then from a payer lens, like here are some things that we know add value. We would like to incentivize the practices to do these things. So these are the things, like, can we at a state level, you know, maintain a list of what's going to bring return on investment? We think traditional health workers might be the thing. It's not a required piece. You know, certainly it's within PCPCH, like Deborah said, let's make the link, but it's not a required. You can be a PCPCH of many tiers without a THW, right? So, but maybe a THW is one of those things that we say there's some data on improved return on investment, and we would like to incentivize that. And then the third piece is that community specific, like meeting a need, filling a gap, reducing disparities, like bus pass. That might work really well for Brian. It's not going to work very well for me. I don't have a bus, right? So that sort of separate innovation piece. So I see sort of like those 3. I would like us to somehow touch on those 3 concepts as separate and distinct.
Okay, thank you. That's helpful. I guess I'll say for the figuring out the delta and what the cost would be to provide versus what's currently paid. So I think this is something that we would need to revisit with OHA to determine what the sort of bandwidth is to do this kind of analysis and keep it updated and whatnot. So so this is noted, and we will bring this back with them. And if anyone from OHA wants to jump in, by all means. But I do think that will require, just want to acknowledge that will require some additional resources on the part of the state.
Yeah, I think that I should let Summer or Chris speak to, or Amy speak to this, but I think it was an issue of resources and expertise. Summer.
Yeah, and I think it was also a question of how valuable it would be. But with this conversation, there's clearly value, so we'll think about that more and come back to you at the next meeting.
Okay, thank you, and thank you, Liz, for that additional clarification. It's very helpful. I just want to acknowledge the comment from Hayes, raising concerns about saying these things can't be aligned with PCPCH if these see these as potentially aligned but needing additional support. So I think, yeah, I think that the recommendation would not be to say that they can't be aligned, but to say that they're areas that would need additional support, or that, you know, if it's already included would need additional support, or if they're not included, they could be things like the bus fare that maybe aren't included in the program. So thank you for that point as well. Okay, so I think given the conversation that we just had, we can skip over number 2. So the recommendation was around sort of prioritizing one or more infrastructure payments, promoting equity, but it sounds like there are other ways that we want to be thinking about, and equity will be included, but other ways to think about that second set of infrastructure payments. So does that make sense that we would add those components? Yep, Liz.
I guess for me, when I'm thinking about that innovations fund, or sort of a community specific or practice specific, that to me is the equity piece. That is that gap that isn't necessarily going to be standardized across the state. And so it does feel important to have an infrastructure payment that specifically promotes equity. And that's how I was interpreting Brian's sort of innovation fund. But Brian, you can correct me if that's not what I heard.
And can I also just clarify though, so that innovation fund, so I think the purpose of that second sort of set of payments was to say that these can be practice specific, right? It would be tailored to a practice's needs. And so not every practice is going to have, yep, go ahead.
Or a community, because
Sure.
sometimes the patients that access a practice are not necessarily all of the patients, and sometimes the gap is those who seek care and those who don't seek care. So looking to address that gap as well. So yes, I would say community specific from a practice lens, who is within the community and knows the community. Yeah.
And so I guess my question then would be, are you recommending that sort of innovation bucket should also have an equity component? I mean, most like, you can imagine perhaps that there could be innovation funds that don't necessarily have an equity component. So are you suggesting adding equity?
I am suggesting it should be equity only.
It should be equity only. So innovation plus equity for that. Okay.
Just my 2 cents.
What, any reactions from others on that?
I think that makes sense. I agree with Liz.
Okay. Well, that addresses, I think, the goal here of also putting a further emphasis on equity. So, okay. So we will take this back, and we will take back the conversation with the state too, and we'll probably, I think we may want to revisit this during the next meeting and just discuss what we've come up with, but we can certainly send out the amended language in the interim between meetings too. Okay, so our last topic for equity, which we're actually going to defer, is around risk adjustment. We are going to talk about clinical risk adjustment in a moment. And then, as I mentioned, we're going to be discussing social risk adjustment during the next meeting, which certainly has a number of health equity implications. And we did, I think we did talk already about some additional equity strategies. Is there anything else that we should be considering for the VBP model outside of the components that we discussed? But I will say, but within the parameters of what we're including in the model. Any additional thoughts? Okay, so let's move on to the topic of, oh,
I'm sorry.
Yep.
It was taking me a minute to get off my camera mute button.
Sure.
I'm definitely not wanting to squirrel. And we've talked about how this is sort of a building the plane as we fly it sort of deal. Do we need, as we're talking about this strategy, to have a reevaluation component or some sort of acknowledgement to that? And if that is not
an evaluation component of the model, you're saying, or
how are we, as our understanding of how this works and our ability to impact equity evolves over time, how is the model and the recommendations in the model responsive to that? And that may or may not be important, but I wanted to say it.
Yeah, so including something around evaluating how the model is impacting health equity. Okay, other reactions or thoughts in response to Liz's suggestion or other? So Liz, why don't we think about what kind of language to include that gets to your point of thinking about how, as this model is evolving, we are continuing to think about equity in ways that the model can evolve to address equity and sort of what we're learning from the model's implementation as it moves along.
Sounds good, thank you.
Yep. Okay. So we are now going to revisit the topic of medical/clinical risk adjustment. And we did touch on this topic many meetings back, but there was lots of conversation, but we didn't quite reach consensus. So here's our opportunity to hopefully do so. We sent around a 1 or 2 pager, I guess, on clinical risk adjustment along with the slide deck. So hopefully you all have had a chance to take a quick look, but I will do a quick recap here of what's on that 2-pager. And really the goal of that is just to lay out things that we previously talked about, which are some of the reasons why clinical risk adjustment should be included in the model, and then some of the considerations or concerns around clinical risk adjustment that should just be acknowledged in thinking about whether to include it, and even, you know, if it is included, just to keep in mind. So the first is that adjusting for clinical risk can account for variation in healthcare conditions and can ensure greater accuracy of payment levels if adjusted for clinical risk. The second is that if we do include clinical risk adjustment, it could help mitigate against potential financial penalties for practices that serve patients with greater medical needs, because they could result in higher capitated payments. Essentially, if a patient does have a higher medical complexity or need. And in theory, at least, and hopefully in practice, clinical risk adjustment would reduce the incentive for practices to seek out healthier patients and discourage sicker, more costly patients. So those are the main reasons why it would be important to include clinical risk adjustment, and then some considerations or concerns that we know exist around clinical adjustment include that there has been increasing literature on the fact that risk scores can be heavily influenced by intensified diagnostic coding, meaning that there can be a financial incentive to code essentially every diagnosis or code them in a revenue enhancing way. The literature on this, I will just note, has been looking at clinical risk adjustment in terms of total healthcare spending, not just primary care focused, but it does exist. And we do cite to some of that literature in that 2-pager. The second consideration is that there is only one known, at least to our knowledge, risk adjustment tool that has been specifically developed for primary care. So most of them have been developed for total healthcare spending. And so the primary care risk adjustment tools may not accurately sort of reflect primary care spending. That tool, we've also learned, was only validated with a small number of practices. And then the last consideration is that clinical risk adjustment doesn't necessarily improve health equity, because we know that underserved populations that receive less medical care can have fewer recorded diagnoses or access care less frequently, and thus generate lower risk scores. And so that can actually lead to some practices being underpaid relative to practices that serve patients that access care more regularly. So again, these are just considerations around the use of clinical risk adjustment. And the goal here is to decide whether to include clinical risk adjustment in the primary care VBP model. I will note, as the top bullet says, we already did agree to include risk adjustment based on age and sex. So that's already in the model. And now we want to revisit clinical risk adjustment. Yes, Liz.
I have clarifying questions. So goal is not discussion at this point. So I'm asking clarifying questions.
Sure.
Clarifying question with bullet number 1, which we have already decided. How are we actuating that in a spectrum of sexuality? Because the data around age and gender, I think, are binary data. So I'm just confused about implementation of that, and I would love to hear sort of how people are thinking about that. And then the other just sort of clarity question, reasons not to include bullet number 2, the one specifically designed for primary care. I think my confusion is our goal is to act within primary care, but to have an impact throughout the healthcare system and total cost of care. So I don't see why that invalidates some of the other analysis, because really we're looking for a whole total cost of care outcome, even though we're only impacting the part in primary care. So I just was sort of having a hard time understanding that.
Sure. So I'll just say on the first one, I don't believe that the current risk adjustment tools and algorithms are sophisticated enough to get at gender identity and whatnot when it comes to sex. But I would ask if others have more knowledge around the current risk adjustment tools and how they work for sex, to please chime in. We can look into that, but my guess would be that that they are not sort of at that level, that they are taking into account gender identity. Bill?
Yeah, I would make the same comment about this that I made before. So this, in my opinion, this section is not helpful in developing a VBP, because it is not specific enough and it does not have any specific advice. And so, like, for example, what does that even mean? Risk adjusting. I mean, what are we talking about risk adjusting? The fact that there's a bullet in there saying that there's no tool specifically designed for primary care indicates that maybe that's targeted at infrastructure payment risk adjustment, or is it supposed to be prospective capitation?
So I think the goal would be, so we're talking about risk adjustment for the primary care capitation payments, and in the very beginning, the group determined that the infrastructure payments would be risk adjusted. So my understanding is that risk adjustment would apply to those two categories or components of the payment model.
Yeah, and so it just gets back to, like, rather than describe a bunch of options, what would be more helpful is some specific guidance. There was an example of specific guidance would be if we look back to the guidance that was provided under the CPC Plus program that was very specific on, here's the way we think you ought to do this.
For risk adjustment specifically? Yeah.
And so, but we don't have anything like that in here. So it's going to leave it to every carrier and CCO to be sitting there thinking, all right, how do we do this? And then you're going to end up with 20 different models. And so it's just one more example of, lists of options and issues. I just don't think are going to get us closer to a model that everyone uses. If we want to have a model that everyone adopts, it should actually be a model that says, here's the way we think you should do it.
Yeah, so I just to respond to that. So I think the goal here is not to provide a list of options around, it's to say yes or no, clinical risk adjustment should be used or not, or it should be left up to the payer's discretion. But I think these are considerations to think about and to weigh. But the goal is to say, to have some level of consistency in terms of the way that risk adjustment is applied for this model.
Yeah, I'm with you on that. But what I'm just saying is to say there's so many different, there's a million different ways that you could do this. And so to say you should use risk adjustment, it just is not super helpful without saying how you should use it.
Medical risk, clinical risk adjustment specifically.
Yeah, I mean, the place that, I mean, we're at MODA and at Eastern Oregon CCO, we're doing risk adjustment in two places. We have risk adjustment for our total cost of care model, where if a practice is held accountable for controlling total cost of care trend, that trend is risk adjusted. We also use it in infrastructure payments. We have it broken up into quartiles. So if patients are in the highest quartile of medical cost risk, we assume that they need that much more infrastructure to support that type of population. But
so you're suggesting
I have no idea, like, is anybody else doing that? I don't know if they are or not.
Okay, so I just want to make sure I understand. So you're suggesting being more specific or prescriptive in how risk adjustment should be used for the purposes of this model.
Yeah, I think so.
Okay. I think it would be helpful maybe to hear some. I think we had a hard time even coming to consensus on yes or no for this question. So I think that's the hesitation in terms of even developing more specific parameters around how it should be used.
And I'll just chime in. I don't actually have an opinion, and we've gotten, and Summer and Chris weigh in here from the VBP Compact work group about allowing more flexibility. So Bill, we hear it from, and I really appreciate your desire for specificity, and we've gotten both from payers and providers, don't be too specific because we want the flexibility. I don't know what the answer is.
Yeah.
And this is Chris, I'll just jump in. My vague recollection is within our toolkit for the VBP Compact Work Group. I'm sorry, the roadmap that risk adjustment strategies is on there. And I'm wondering if we could kind of get more prescriptive about, not prescriptive, but provide some guidance around different approaches, maybe add that to the toolkit at some point. I don't know. Summer, Diana, what do you think?
Yeah, I think that's an idea.
Thanks, Chris. Diana. Deborah?
Unfortunately, I do not have the answer to your question. And it's I think acknowledged, and it's similar to what I put in the chat, that I do like the idea of risk adjustment for infrastructure payments because it can reflect the population. However, as you have acknowledged, existing risk adjustment methodologies I don't think are made or derived for the purpose of primary care payments. It is for total cost of care, which to me is very different, and don't reflect the support needed to be provided within primary care. So, and this is again, PED specific, you could probably apply it to different types of populations for different reasons, but pediatrics total cost of care is not very high. The need for infrastructure and supports for preventive care rather than chronic care management is very, very high. And the more we can do, the higher return you will have 15, 20 years down the road. And so the current payments that have been based upon adult populations or Medicare populations have really crowded out the supports needed within the pediatric population, or a practice will focus on the adult population in a family practice and not include the kids. So that's perhaps an argument against the clinical risk adjustments as they currently exist for total cost of care evaluation. But I don't know that age and sex also, I don't think that that's going to be perfect, because again, I think that it will be undervalue the younger population because it's still thought of in a total cost of care context. So I think regardless of which one, I think you're still thinking about it unless it's adjusted to consider what supports you want provided by primary care in those populations. And I don't know that there's any model or anything to prove it out. So it's just more cautionary thoughts. But I worry that again, anything that includes age will crowd out payments that are needed, very important payments needed to really enhance what's provided within pediatric primary care because the total cost is less. And I can let Hayes speak to the some of the complexity models that OPIP has put forward that I think are better reflective of the needs.
Okay. I see Liz's hand, and I know, Liz, we didn't totally probably answer your questions either from the beginning. So Hayes, do you want to speak to that now more, or, and then we'll go to Liz?
Oh, sure. I was just echoing that piece as well. Sorry, I'm driving from a site visit for one of our pediatric grants, but I pulled over. So basically, I think the bottom line is, you know, we know that exactly as Deborah was saying, if we're going to compare kids to adults that on a total cost of care basis, that we're going to see, you know, higher total cost of care for adults. And I think just figuring out what we would suggest, but there has been a lot of discussions about if you're going to encourage more investment in children, right, you're going to encourage some of that preventative care, then you've got to take into account that childhood medical complexity, social complexity as well. And I know social complexity is separate, but there are models out there to look at that in children. And I think at the very least, not using a model that compares children and adults head to head, but use a separate risk adjustment model that looks, okay, in your pediatric population, how many of those children are complex, and just determine your payments, whether it's capitation or infrastructure, based on that, and then look at the adult population separately so that you're at least not comparing the two. Agree, there's no perfect model out there, but we do have some state level data on medical complexity in children with our child health complexity data.
Okay, that's helpful. Thanks. We will take that back and think about how to acknowledge that in whatever we end up including in the model. Liz?
Yeah, I think I'll try to be succinct, two pieces. I absolutely agree with Bill's statement that this should be prescriptive rather than allow for flexibility. I think the whole point of coming up with a model is to say, this is what is most likely to be effective, and having different takes or different opinions from the 280 plus carriers that we contract with makes it inactionable. And so understanding how this is going to play out, it needs to be standardized, just like metrics need to be standardized in order for us to be able to have the desired impact. I think.
Yeah, go ahead. No.
Yeah, I have a grave fear around not doing any sort of clinical risk assessment because of the risks of worsening the inequities of the patients seeking care, and agree with the premise that not all patients seek care. And so there is a gap there, right? And so, you know, that could be something we intentionally focus resources around addressing, like who's not coming in, but not having clinical risk adjustment carries substantial risk of widening disparities in outcomes for those who come in, because it disincentivizes practices to care for sicker patients. And agree with Deborah that and Hayes that I think we're looking at this wrong. I recognize I'm talking myself in circles. I'm saying this out loud because I don't really know how to reconcile it internally. But all of the stuff that we're talking about is retrospective. It's like, how much did these patients cost? Let's invest some resources in the patients who cost the most in the hopes that they won't cost so much moving forward. You know, I get those lists from MODA, and like half of the people on the list are dead, right? They cost a lot because that's where they were in their life cycle. And, you know, I have this newborn baby who has 0 health conditions and 0 medications and looks great and is in this chaotic social life that I know they're going to cost the system a ton by the time they're 20 years old. but there's no way for me to show that, right? So the problem with risk adjustment is that we've got to both deal with what's going on now, also bring people into the system who aren't accessing care, and at the same time get upstream of it. And I think those are three different things. And if we try to do it all with one model, it's not going to work very well.
Yes, okay, thank you for that. And so a couple of thoughts. One is that I hear you and Bill and potentially others saying that we need to be more prescriptive, and I think we need to get to a yes or no on whether we are using risk adjustment, clinical risk adjustment, before we can get more prescriptive. And I'm not hearing total consensus on that, but I'm hoping we can get there, and then we can talk about how to be more prescriptive if that's the direction people want to go in. And then the other thing is that I think what the feedback around the inadequacies of the current tools when it comes to children and exacerbating existing disparities are all unfortunately part of the shortcomings and challenges that exist with the current tools. And so I think that's also an ongoing conversation, and this flows into next month's topic as well, but sort of we have to acknowledge the tools that are that we currently have. And so when we're talking about medical risk adjustment right now, yes, we can think about sort of ways to think about children's medical complexity and using that, but otherwise we are also unfortunately limited to the imperfections of the tools that are currently being used. So can I ask
why? I'm sorry, I'm just confused. Why are we limited by the imperfections of the tools that are being used? If we are going to say that we want to go more upstream, then we would weight risk adjustment differentially to try to do more for younger population. Like I'm
weighting it differently. Well, in
that.
other words, the risk adjustment sort of software and algorithms are, I mean, I will have others speak to this with more expertise, but those can't be changed. There's potentially ways, I mean, there could be new ones that are being developed, which is what we're trying to do with social risk adjustment. But the existing tools, you know, have their challenges. And so we can talk about ways to use risk adjustment to weight payments in a different way. Is that what you're talking about?
Maybe. So, okay, I'm going to try and say this back to make sure I'm hearing it right. So we need a yes or no on clinical risk adjustment using an established tool. And if we decide yes, then we could decide how we apply that in a way that might get us more upstream. Is that what you're saying?
That's my understanding of how this could work.
And then we're having a separate conversation around social risk adjustment. And so if we really think like the biggest driver for complexity is actually sort of the underlying social strata, maybe we say no to clinical risk adjustment and we say yes to social risk adjustment, and we hope that that swings us upstream. Is that what you're saying?
Yeah, I mean, we could certainly revisit medical risk adjustment next week, but I guess I'll say I think it's going to be challenging for the group to land on a very concrete decision on social. I think that's going to be a longer term conversation too. So I guess I don't want to give any sort of false hopes of having a lot of clarity around social risk adjustment necessarily by the time that next month comes along. Bill?
Yeah, I would have a specific suggestion on what we could do with this language that maybe people would be on board with.
Great. Let's hear
it. When you're talking about risk adjustment, to just be more specific about what that means. And so in my mind, there are at least 3 different places where you could apply risk adjustment. And one of them, to me, seems super easy. It's a no-brainer. The answer is yes, you should do it. And that is if you're going to measure a member on their total cost of care, or measure a practice based on the total cost of care of their members. That's what risk scores were designed for, and it's widely used in the industry already, and that seems like a no-brainer that people would continue to do that. A second thing that you could potentially use risk scores for is to risk adjust prospective capitation that's generally covering numbers of office visits. And I think that we are acknowledging that there's no great tool out there, and that risk scores based on diagnoses are not that great with estimating how much primary care somebody's going to need. And so the answer to that one is probably no. You probably shouldn't do it. There's probably better ways. And in my opinion, and this is the way we do this, that a better indication of what the capitation rate should be, if you want to capitate office visits, would be last year's level of utilization. And then the third thing would be these other types of payments. Maybe there are some, maybe people would agree that in general, adults with a lot of chronic conditions on average are going to require more infrastructure than, say, kids. And but that's more of a gray area where there's differing points of view on that. And maybe the answer is that risk adjustment might be helpful there, but to address some of the issues that Deborah and Liz have brought up, I mean, maybe there should be some limits as to just because you have a bunch of kids that are going to have low risk scores, that you shouldn't shrink the infrastructure payment down so much that the difference between the highest level of payment and the lowest level of payment is great, because that means the kids are going to, the pediatric practices get hardly anything. So maybe you do risk adjust it, but if you do, you don't, you make sure that there's some amount of variance, some limited amount of variance between what the different payout levels would be for the risk scores, if that may. I'm not sure if I said that clearly or not, but for those types of payments, maybe there's an opportunity, but you'd have to be careful about how you do it. And so that would be specific guidance that I think somebody could, a carrier could take and run with that.
Bill, can I put you on the spot and ask if, I'm sure we were all typing furiously, but I'm wondering if you could throw that in an email.
Yeah, sure.
Because you got Liz saying yes, you got Deborah saying yes. So look, I don't know if other folks have serious concerns, but I wonder if we should just look at that.
Yeah, I think that'd be helpful, Bill. And I just want to, so risk adjustment for total cost of care, I just want to acknowledge that would be outside the scope of this model, though.
Total cost of care is a VBP.
Yeah.
Right, but we're talking about, but I'm saying outside of the scope of the primary care, it's outside, it's not impacting the primary care prospective payments or the primary care infrastructure payments for this model. Is that right?
I think that that's one. Certainly the total cost of care is addressed as an option that payers could include. I was just in a meeting earlier today where we're talking about the cost growth target group and how primary care practices are now going to have their results made public on how well they're controlling total cost of care trend, and that's coming soon. I just acknowledging that this, including total cost of care in this model, has been it's not been universally popular in this group. I just don't see how you avoid doing that, looking at what's coming.
Okay, well, we were supposed to get to total cost of care, but didn't get to it this meeting. So we will have to bump that to next meeting too. So stay tuned, and you can take a peek at the slides for a sneak preview. Okay, this is helpful though. And I think if you can send this, put in writing, I've tried to capture here what you've said, and it looks like, I'm just peeking at the chat above on my other screen, it looks like there's some support for it. We can then incorporate that into what the model to date, and solicit feedback. And then I think the other thing is, Bill, if you have suggestions for your recommendations around being more prescriptive. If those recommendations go beyond what you just stated, that would also be helpful.
Sure.
Okay, well, we are officially over time. Thank you, everybody, for all of this wonderful feedback. The other topic that we did not get to, which I know there's a lot of interest in, is behavioral health integration and how we can incentivize that and pay for it in the model. And so I will request that if people can also take a look at the recommendations that we have for behavioral health integration, because we're going to also have to address that during the next meeting. That way we can come prepared to all talk about it. And if there's initial feedback that you would like to share in response to the recommendations that are being proposed on behavioral health integration, it would be helpful to hear that in advance to help us move more efficiently in that discussion as well.
Thanks,
Okay.
everybody.
Thanks so much.
Bye.
Bye.